patients with that who had metastatic disease when they were diagnosed, the standard option would be gemcitabine and carboplatin for almost all patients who were not eligible to get cisplatin-based chemotherapy. And the historical data goes back to a study from Europe where the median survival was about 9 months. And the response rate was in the 30s, mid-30s, in terms of objective responses. And so really not very good outcomes, obviously, for those patients who tend to be a little frailer, tend to have some more comorbidities. More recent studies have shown that gemcitabine and carboplatin with modern supportive care and maybe just better care overall might be a little longer than that, maybe 12 to 14 months. But even so, still not a great number. And so most patients would be falling into about a year range, is my guess, in terms of longevity. And, you know, with maintenance therapies, with immunotherapy, that number is probably now longer than that because of the introduction of maintenance avelumab, but still maybe in the 18 to 20-month range at the most, is my guess. So the first trials that got enfortumab approved were based on phase 1, 2, and then ultimately phase 3 data in patients who had PD-1, PD-L1 refractory and platinum refractory disease, or platinum experienced and PD-1 experienced. And in this context, the response rate was in the low 40s, which in a refractory setting is pretty impressive. And it was also, and the median survival was a little over a year, maybe 13 months in those studies. And the randomized phase 3 trial, EV301, showed that, in fact, it was better than standard chemotherapy in that setting, in the refractory setting. And all of that data, plus data understanding the interaction of the immune system with antibody drug conjugates, and particularly MMAE, which is the vedotin part of enfortumab vedotin, led to the design of EV103, which is the study that led to the accelerated approval of the combination of EV-Pembro. And that was a multi-cohort study looking at different combinations of treatments, not just EV and Pembro, but in some cohorts adding chemotherapy to that combination, or chemo, or EV plus chemo without Pembro. But the real winner in all of that was the enfortumab and pembrolizumab combination, where the first cohort of that study, cohort A, along with the phase 2 dose of the phase 1 part of it, so dose escalation / cohort A, showed that 73% response rate, which really blew all of our minds at the time. And the follow-up data has shown from that study that this appears to be quite durable, that the median duration response was 25 months, and in 73% of patients. So 73% of patients had not progressed, and half of them had not progressed until 25 months is really what that means, which is an extraordinary number. And the median survival was 22 months compared to 9 to 12. And so that led to cohort K, which was the randomized study that led to the FDA approval, which was, for the accelerated approval, it's EV-Pembro or EV monotherapy in metastatic, cisplatin-ineligible, untreated metastatic disease with urothelial cancer, and showed very similar results, with a response rate of 64.5%, with the duration of response not reached, the median survival, data is not mature, but over 20 months. And when combining cohort A and cohort K EV-Pembro, you get a response rate of 68.5%, which, again, in a cisplatin ineligible population who might not get really great therapy, is quite a it appears to be quite an improved outcome compared to historical data. So there's a large randomized phase 3 study called EV302, which is comparing EV-pembro to gemcitabine and platinum, either cisplatin or carboplatin, depending on what the patient's a candidate for. And that study is to confirm the results and hopefully lead to full approval as opposed to accelerated approval, and also lead to worldwide approval of the combination. And we're hoping to see those results in the next year and a half. We expect that, and my expectation is that the data will support the full approval based on what we've seen in a sicker, less fit patient population. Although cisplatin, we haven't beaten cisplatin yet in advanced bladder cancer, and so we'll see where this study ends up reading out. In addition to that, there are two other phase 3 trials that are ongoing. One of them is in cisplatin eligible patients who have muscle invasive bladder cancer. This is locally advanced disease or locally invasive disease, randomizing them to either chemotherapy with gemcitabine and cisplatin or enfortumab and pembrolizumab as combination therapy as neoadjuvant, and then there is a postoperative adjuvant period on the for patients who are getting the experimental arm. And the second study is for patients who can't get cisplatin in the perioperative setting. They're randomized to either EV-pembro or just going followed by surgery or just going straight to surgery. And so those two trials might extend the indication all the way to locally advanced muscle invasive disease that are resectable. And so, in fact, before the first line setting, right, maybe prevent increasing cure rates, preventing people from developing metastases. And so it may eventually be that this is a treatment for stage 2 and 3 disease in addition to stage 4 disease. It's a very different type of toxicity profile. And I don't want to minimize the toxicity of EV and pembro. I think that at times it can be a very difficult regimen. So there's a fair amount of skin toxicity with skin rashes. Very rarely you get life-threatening skin reactions. And with EV alone, and probably not more with EV pembro, but still because enfortumab is in the mix, it happens. You have a little bit more pneumonitis than perhaps with enfortumab alone or pembro alone. But you don't have a lot of cytopenias, low blood counts, that you get with gemcitabine and carboplatin, which reduces the ability to give the treatment. And so patients often are able to stay more on schedule from a blood count perspective with EV pembro, but they may encounter other sort of immune-related toxicities or enfortumab-related toxicities. One of the issues that might preclude someone who is cisplatin ineligible from receiving enfortumab is that if they have significant peripheral neuropathy, enfortumab will probably make that a lot worse, and as time goes on. And so those patients may not be the optimal candidates. And there is some evidence that people with very poorly controlled diabetes may not do that well with enfortumab until you control their diabetes. And then in fact, it seems like it's safe, but there are, we know that enfortumab and pembro can cause some hyperglycemia once in a blue moon. It's a very serious, really bad hyperglycemia requiring an ICU stay. But with enfortumab, so there are some patient categories that gemcitabine and carboplatin might be better for them, at least initially. But the toxicity profile is probably more just different than necessarily easier of the one or the other.